I hope you're all still with us. It's a whistle-stop tour, but hopefully you're finding interesting points through these cases. So I'm going to just conclude now with a short example of personalised medicine in cancer care. And that's going to briefly introduce cancer as a genetic disease, as we've heard about already this afternoon. I'm going to talk a little bit about BRCA1 and BRCA2 genes, building on what Professor Donnelly said earlier, and then use ovarian cancer as an example of how we can use personalised medicine in the clinic with patients and how there's relevance to prognosis, treatment and prevention. So as you heard earlier, cancer is inherently a genetic disease. So we have in each cell of our body our two genomes, our two copies of our genes, one from our mother, one from our father. And we start out life with a relatively clean palette, with no mutations in our cells. But as we go through our life course, we accumulate mutations. Some of those are accumulated just in the normal division of cells, and some of those are accumulated because of environmental exposures, such as sunlight or cigarette smoking. Your cell has mechanisms for repairing that damage, but if the mutations fall in key proteins, in key genes, that control the cell function, then it can cause a cancer to grow. So this is a cancer genome. But every cancer patient has two genomes. They have the genome in their cancer cell, and they have the genome in all the rest of their cells, which was the static one that they were born with. And it's mutations in that germline genome that I'm going to talk about today. So just to recap that, most individuals start with two normal copies of a gene. And across their life course, they need to get a mutation in both of those copies for the cell to divide uncontrollably and become a cancer cell. But a small proportion of people inherit one copy of a faulty gene. And therefore, their pathway for that cell to become a cancerous cell is shorter. And that's what happens with people who've inherited a BRCA mutation. So a healthy cell accumulates DNA damage, and BRCA is a protein, amongst others, that repairs the DNA in your cell and takes it back to being a healthy cell. So if you lose the function of BRCA, either through just in one cell in a cancer cell or through inheriting the first fault and then developing a second fault, you can't repair your DNA damage as effectively. That damage will accumulate and the cell will either die or become a cancerous cell. So now to our patients. Carriers of germline BRCA1 or 2 mutations, so people who inherit those mutations, are at high risk of developing breast or ovarian cancer and also have a modest increased risk of prostate and pancreatic cancers. Ovarian cancer occurs in 7,500 women each year in the UK, and it causes about 4,500 deaths each year. And that's partly because about 80% of these women present late. And the reason they present late is partly anatomy, and it's partly to do with lack of symptomatology. But overall, there's a poor prognosis. So the overall 5-year survival rate is just 31%, which in the field of oncology is relatively low. Over 90% of ovarian cancers are epithelial in nature. And for these ovarian cancers that are epithelial, these patients, about 10 to 15% of them will have an underlying germline BRCA1 or 2 mutation. Just to challenge traditional paradigms, that figure of 1 in 10 women is not based on family history. That is, every woman that comes through the door in the oncology clinic with a new diagnosis of ovarian cancer, 1 in 10 of those women, regardless of family history, will have an underlying BRCA1 or BRCA2 mutation. So how does knowing whether a patient has an underlying mutation in BRCA1 or 2 help us in clinical care? Well, it gives us information about prognosis. So these women who have this underlying mutation have an increased sensitivity to traditional chemotherapy agents, which results in longer disease-free intervals and longer overall survival rates. They have a better prognosis. Again, challenging a paradigm where hearing that you have a genetic mutation is bad news. In these patients, it is good news. It's important information if you have just been diagnosed with ovarian cancer with the poor prognosis that traditional treatments give for these women. Secondly, it affects our choice of treatment, and that's with the development of a new treatment called PARP inhibitors. So, in normal tissue in these women, they have a normal functioning copy of BRCA1 because they've got a mutation in one copy, but their second copy is working normally. That means if there's DNA damage on a single strand, a protein called PARP will repair it. And if there's DNA damage in both strands of the DNA, BRCA1 will repair it, and that's the normal state of affairs. In the tumour cell, however, they've lost their second copy of their BRCA gene, so they have no pathway mending their double-strand breaks in DNA. They still, however, have their single-strand break repair. But PARP inhibitors do what they say on the tin. They inhibit the protein PARP. They stop that from working. So when given to a woman with ovarian cancer, the normal tissue is not affected because there is a rescue pathway. So single-strand breaks can be made into double-strand breaks, and the cell can mend those with their BRCA pathway. But if you give those PARP inhibitors to women with ovarian cancer, the tumour cells don't have that rescue pathway because they have no functioning BRCA. And that means that the tumour cells will die. And it works. So in these women, giving PARP inhibitors causes a significant response at just 4 months of treatment. These treatments are not yet on the NHS. They're in phase 3 trials, so they are still in development. But this is the first targeted treatment for BRCA mutation carriers that's been shown to work. And lastly, knowing a woman's underlying genetic information will help us prevent further cancers. So identifying an individual with an underlying BRCA mutation allows us to test other members of her family. Now, some of those women will be negative, and that will remove a level of worry. But for those that are positive, there's an opportunity to prevent them from developing ovarian cancer through relatively simple prophylactic surgery once they've completed their families. Now, I've been talking about women who've been inheriting a mutation, but as we said right at the beginning, cancer genomes themselves have a variety of gene mutations collected over the life course of that cell. And this slide just summarises or tries to show that there are many different targets for treatments being developed at the moment, and PARP inhibitors are just one of those. So it's simple. A patient comes to the clinic, is diagnosed with cancer. We sequence their genome, we sequence their cancer genome, and then we use that information, perhaps run it through a database of treatments available, and produce a report for an oncologist about what is the best management for that patient. Well, anybody here involved in either the science or the clinical side knows that that is a far from simple pathway. There are several challenges that are specific to cancer care, and Professor Donnelly touched on some of those earlier. One is that the type and number of gene faults differ from one cancer to another, and even from one cancer to another within the same type of cancer, so ovarian cancer or breast cancer, as Professor Donnelly showed us. But even within the same tumour, there's differences. So if you take a biopsy from an ovarian tumour and then take another biopsy from another bit of that tumour, those two biopsies will show different genetic signatures. Furthermore, gene faults in a tumour may change over time, so you have a bit of a moving target. And as Professor Donnelly explained earlier, there is this element of resistance to treatment that cancers seem to be able to develop. A single cancer type might have very small numbers of patients when looking at the genetic subtypes. So trials need to be adapted to show whether drugs can work. And then I've put it as one point, but it's what I spend most of my time doing. So looking at the infrastructure and clinical pathways required to implement this type of information in the NHS is a huge challenge not to be underestimated. So I've just got a few questions, similarly to the others, to leave you or to get you thinking. And one of them is an area of interest of mine. Should there be a boundary between research and clinical medicine? And that boundary between research and clinical medicine crosses many areas. And we heard a little bit about access earlier. So should there be a healthcare scenario whereby if you live in Oxford or in London, you have access to the best genomic testing and personalised medicine, but if you live in Truro, you don't have access to it? how do you get tests that work in a research setting into the NHS? What is it about testing in a research setting that's different to how it needs to be in an NHS setting? And who's going to pay? Who's going to pay for at the moment, these tests done in research are not paid for by the public sector. And lastly, there's this issue of trial redesign for drugs to show the efficacy in small numbers of patients. So you've come to the end of our journey through examples in personalised medicine. And just to finish this section, I'd like to add my thanks to that of the principals, to the Dr. Stanley Ho Medical Development Foundation for their generous support of our centre. And very much I'd like to thank the St Anne's Development Office for all their hard work in the preparations for today, and both Professor Donnelly and Tim Garden for their support. Thank you.